So, welcome back to Doctor's Desk. In episode 1, we discussed the general approach to critically ill patient like ABCs, ICU interventions, and the severity scores like SOFA, Apache 2 scores. In this episode, we will continue the journey into critical care medicine. We'll cover other topics like respiratory failure, multi organ failure, and other monitoring in ICU. So, first, we'll dive into the respiratory failure. So, what is respiratory failure? It means inability of respiratory system to maintain adequate oxygenation and or CO2 elimination. So there are four types of respiratory failure: type 1, type 2, type 3, and type 4. So we'll see type 1, so which is acute hypoxemic respiratory failure, which means hypoxemic due to ventilation perfusion mismatch, where oxygen is less than 60 mmHg and carbon dioxide is normal or low. The, the etiologies for type 1s are ARDS and sepsis, gastric aspiration, pneumonia, COVID 19, and near drowning and multiple blood transfusions, and pancreatitis. So, literally around 50 to 70% mortality rate is higher in ARDS. That's what Harrison tells, and the mainstay of treatment for this type 1 failure is ventilation. So we keep the patient in ventilatory system like mechanical ventilation. So what Harrison tells is mechanically ventilated patients with ARDS may propagate to lung injury also. Like there is a graph in Harrison telling about there is a volume and pressure relationship where the y-axis tells about the volume and the x-axis tells about the pressure. So if you see here it tells about the alveolar diagram, the size. So the less the pressure, the alveolar gets collapsed. When the pressure gets increased to the mechanically ventilated system, the size increases. Though if you increase the size like 30 to 45 and all, this gets over distended. So repeated stretching and over distension happens in higher pressure. So this is also called as volume trauma or ventilator induced volume trauma. That's what Harrison tells. I have underlined about it. So in ARDS, patient should always be kept in low tidal volume to maintain this pressure volume relationship. That's what Harrison tells. Then then we'll go to type 2 respiratory failure. Type 2 is hypercapnic, where there is increased CO2, usually with hypoxemia. The causes are like COPD, CNS depression, neuromuscular weakness, chest wall disorders, and I've underlined here like myasthenia gravis, Guillain-Barré syndrome, and amyotrophic lateral sclerosis, or other respiratory muscle weakness, which I have told earlier. So the mainstay of therapy for hypercapnic respiratory failure are directed at reversing the underlying cause. So it's to reverse the underlying cause. Like if it is myasthenia gravis, you have to reverse it by giving treatment to myasthenia gravis. So type 3 is about lung atelectasis or preoperative or postoperative collapse. This form of respiratory failure is usually seen in perioperative. Like there's patients who are going to surgery like that. So this can be avoided or managed by change in position and chest physio and uprighting position and control of incisional and abdominal pain. And type 4 is shock related, like metabolic demands. This form of respiratory failure most often results from hypoperfusion of respiratory muscles in patients in shock. So I told it's type 4 is it's basically shock related, occurs with circulatory collapse and respiratory muscles tire due to hypoperfusion. So in respiratory failure patient, the evaluation starts at the bedside, looking for work of breathing, mental status, cyanosis, and the respiratory muscle usage, and saturation, ABG will be seen for respiratory failure evaluation. Yes. And we can go for imaging, then ABG analysis. We can the crucial step is to identify what type of respiratory failure, and we can give the appropriate management. So next is care of mechanically ventilated patients. So once a patient is ventilated, survival depends on not just on settings, but how we care for them daily. So there's something called lung protective strategy, keeping them in low tidal volume, keeping them in plateau pressure, and using adequate PEEP and positioning and other stuffs to maintain this mechanically ventilated patients. So these patients require sedatives and analgesics. Sedatives used like propofol, benzodiazepines, and lorazepam. I mean benzodiazepines like lorazepam and midazolam, and analgesias like opioids. These neuromuscular blocking agent like cistracurium is occasionally used to facilitate mechanical ventilation in patients with profound ventilator dyschrony despite optimal sedation, particularly in setting of severe ARDS. Uh, this prolonged usage can lead to myopathy, which is called as post-paralytic syndrome. So in basically in ICU, patients often will have renal or hepatic dysfunction due to uh, drug accumulation. Because of these lot of sedatives and analgesias, a lot of drugs will be going to the patients. So and importantly, I forgot to tell that patient will have amnesia. It is a mandatory for all the ICU patients, or like whoever is sedated and in mechanically ventilated patients. So yeah, so what I was telling was these lot of drugs getting accumulated during mechanically ventilation period. So the, the main thing to reduce this is reducing the period for mechanically ventilation. Like we have to we have to try we have to try to wean and extubate the patient. So there are a lot of criteria to extubate, but what Harrison tells is there's some protocol like nursing protocol or spontaneous awakening trials will be done by the nurse or the physician um, to extubate them. So the period of mechanically ventilated period can be reduced, and other cofactors in like infections and wound healing, all the other factors will be helpful to be reduced. So what actually happens is what actually happens is we have to screen daily about the oxygenation and intact cough and airway reflexes, and no usage of vasopressors or any sedations. If all these criteria meets, we can go for spontaneous breathing trials. That's what Harrison tells over here. So for the spontaneous breathing trial, we see all these criteria like oxygenation, cough, no vasopressors, and heavy sedation. Then, if the patient meets these criteria, then we will try the patient for spontaneous breathing trial. What will they do is CPAP. I have wait, I will show you. CPAP 5 centimeter H2O with or without low level pressure support, and an open TPS breathing system have all been validated for 30 to 120 minutes. So for 30 to 120 minutes, this spontaneous breathing trial will be done with the mode of CPAP 5 centimeter H2O and low PS or TPS breathing system. So sometimes this spontaneous breathing trials can be failure, uh, like the respiratory rate more than 35 bar minute for more than 5 minutes, or oxygen saturation less than 90%, or a heart rate more than 140 per minute, or a 20% increase or decrease from baseline, or systolic blood pressure less than 90 or more than 180, or increased anxiety or diaphoresis. These are the criteria where which is where you can tell spontaneous breathing trial is failure. So if none of these occur, patient passes spontaneous breathing trial, and then candidate can be extubated. So after extubation, about 10% fail and require re-intubation. Immediate re-intubation is usually safer than delaying with non-invasive ventilation. Select cases may benefit from non-invasive ventilation or high-flow nasal oxygen right after extubation as a bridge. So basically, the ventilator care bundle is daily readiness for weaning, head and bed elevation like 30 to 45 degrees. Like we have to maintain the elevation, then oral hygiene, suction care, then we have to minimize the circuit breaks, stress ulcer, DVT prophylaxis, nutrition with 24 to 48 hours, and we have to target glucose within 140 to 180 mg per deciliter. This is how we have to reduce the ventilator days and ICU stay. Next, we see about the multi-organ system failure. Um, it is defined as progressive dysfunction of more than two organ system. So the main criteria is more than two organ system after an acute insult. So most common causes are sepsis, ARDS, and shock. Then so the scoring system for it is SOFA score over 48 hours can be a poor prognosis, and also lactate that doesn't clear is a warning sign. Then we have to give organ support for each system. Like respiratory, we have to use ARDS strategy, and for cardiovascular system, we have to use norepinephrine and or vasopressin and fluids. For renal system, we have to use CRRT in unstable patients, and for hepatic system, we have to go for supportive and avoid hepatotoxin drugs. Then for hematology, DIC support, then transfuse if needed. Then neurological system, we have to maintain the perfusion and manage seizures, epilepsies and stuff. And for metabolic demands, like we have to maintain the glucose and correct electrolytes. And for nutrition, then early enteral and adequate protein is needed, and we have to maintain the glucose. So outcome is mortality rises when the organ number increases. Next, about the monitoring in ICU. Finally, ICU monitoring um, is very important fundamental in ICU. Like basic continuous monitoring is must in ICU. That's why it's very special place in hospital. So basic continuous monitorings are like ECG, oxygen saturation, BP, respiratory rate, temperature, urine output. Always we have to look at the trends, not the single numbers. So for oxygen and perfusion, we see ABG, ABG for O2, CO2, pH. Then we have to track AA gradient, lactate, and other stuff. And for hemodynamics, heart for arterial line for beat to beat BP. CVP is limited alone, but trends and stuff. Bedside ultrasound is a gold standard for IVC collapse. We can see through that bedside ultrasound. Then ventilator monitoring, then sedation, neuro, then other safety checklist can be monitored in ICU. Basically, you have to monitor each and every checklist, like a lot of checklists, like checking for oxygenation and hemodynamics, ventilator monitoring, and all those stuff. There should be a continuous monitoring in the ICU. That's what ICU says. Then I have underlined that gold standard for monitoring in ICU is obviously ABG analysis. Then talking about pulse oximetry, the most commonly utilized non-invasive technique for monitoring respiratory function. And we have seen these things in hospital, but we never wanted to know how this works under what principle. So here it is at wavelengths of 660 and oxyhemoglobin reflects light more effectively than does deoxyhemoglobin, whereas the reverse is true in infrared spectrum. So basically, the pulse oximeter passes both wavelengths of light through the perfused digit, such as finger, and the relative intensity of the light transmission at the two wavelengths is recorded. So pulse oximeter is designed to detect only the light of alternating intensity. So now let's get into respiratory system mechanics. So I don't want to confuse you guys with these things, so I'll explain it in a structured way. So when using volume controlled modes, airway pressure can give us important information like two things: peak airway pressure and plateau pressure. Peak airway pressure means airway resistance plus respiratory system. That's what Harrison tells. So peak airway pressure means airway resistance plus respiratory system compliance. And plateau pressure only compliance. So The difference between peak airway pressure and plateau pressure tells us about the airway resistance. So more than 10 to 15 centimeter H2O, think that it has increased resistance. It is seen in asthma and COPD secretions. So yeah, that's what the thing is. Also, compliance means change in volume divided by plateau pressure minus PEP. This kind of complicated mathematics, but yeah, this is the true things in Harrison. So normal respiratory system complaints is 100, and complaints falls in pneumonia, pulmonary edema, ARDS, pneumothorax, obesity, and abdominal hypertension. So low complaints is high plateau pressure. That's what Harrison tells. Then they tell about the auto PEP. Happens when alveoli don't fully empty before the next breath, which is called air trapping, which is commonly seen in asthma and COPD, leads to alveolar distension, increased plateau pressure, and risk of barotrauma. So the modern ventilator shows real-time pressure, flow, volume loops. These allow detection of patient ventilator dyschrony, airflow obstructions, and auto PEP. So in ICU, we should always track both the peak airway pressure and plateau pressure. It helps us to distinguish obstruction and compliance problems. So basically, it's about we have to find the patient is in obstruction disease or compliance problem disease. That's what this respiratory system mechanics tells. So next we'll be seeing about the circulatory status. So what exactly they are telling in that is there's some complicated max over here. They are telling that this much amount of O2 is delivered to the tissues, which is bound to hemoglobin. These things are actually calculated via the pulmonary artery catheter. So the pulmonary artery catheter originally was designed as a tool to guide therapy for acute myocardial infarction, but has been used in the ICU evaluation for and treatment of a variety of other conditions such as ARDS, septic shock, and congestive heart failure, and acute renal failure. So that's what they say in this phase. You can just remember this value. No need to get into deep and confuse yourself. So then we see about the prevention and complications of critical illness. So just we can just see for 2-3 points in each contents. Like sepsis, obviously we see in ICU, which is the main thing we see in ICU. So an increase in SOFA of 2 or more points is poor outcome in sepsis. This can be prevented by the regular measures and antibiotics and stuff. Then nosocomial infections in the ICU. These interventions include endotracheal intubation, indwelling vascular catheters, transurethral bladder catheters, and catheters placed into the sterile body cavity can cause nosocomial infections. Then ventilator associated events such as ventilator associated pneumonia correlate strongly with the duration of intubation. and mechanical ventilation. So the duration of intubation can be a factor for ventilator associated pneumonia. Then these infections control is critical in ICU, and this can be prevented by care bundle measures like hand washing, uh, then protective isolation. Patients colonized or infected by drug resistant organisms should be isolated, and frequent changing in these catheters can help in uh, preventing the infections. Then DVT, all ICU patients are at high risk for deep vein thrombosis. They should be given chemoprophylaxis or prophylaxis for this DVT. Most commonly used is low dose heparin. So the low molecular heparin such as enoxaparin are more effective than unfractionized heparin for DVT, which is high risk, given in high risk patients. Some patients may develop heparin induced thrombocytopenia, so it should be limited in such kind of patients and stuff. And also we have to check for their renal clearance. Then stress ulcers, usually they give proton pump inhibitors for stress ulcers. There has been a study saying that there is increased risk of pneumonia and Clostridium difficile colitis with PPA usage, but it's not a definitive data. Then nutrition and glycemic control. Nutrition and glycemic control are important issues that may be associated with respiratory failure, impaired wound healing, and dysfunctional immune response in critically ill patients. So we have to maintain the glucose level around less than or equal to 180 mg per deciliter. So it is glucose control is very very important in ICU, which can be helpful for recovery of the patients. Then ICU acquired weakness. Obviously, all ICU patient will have the myopathies and stuff. So early physical and occupational therapy in mechanically ventilated patients can improve that weakness. Then anemia, which is a result of chronic inflammation, and also there will be frequent phlebotomy happening in ICU, so that's also a factor for anemia. And then acute kidney failure is also seen in critically ill patients. Most common etiology is acute tubular necrosis. Currently there is no pharmacological agents available for prevention of acute kidney injury. Then other neurological dysfunctions is like delirium. It can be defined as acute onset of changes or fluctuation in mental status, inattention, and disorganized thinking and altered level of consciousness. That's what defines delirium. So in ICU they do this confusion assessment method for ICU, CAM ICU. You can remember it as CAM ICU, or intensive care delirium screening checklist. They just ask the simple questions, bedside questions, like you can just check it out in net and see this checklist. So there are interventions to reduce ICU delirium are limited. The sedative dexamethasone has been less strongly associated with the ICU delirium than midazolam. So next, anoxic cerebral injury. It's commonly seen in cardiac arrest. So active cooling of patients to 33 degrees after cardiac arrest is still a controversial, with some studies showing improved neurological outcomes and others such as others showing no such improvement when compared to maintaining normothermia. So stroke, it is also seen in ICU patients. Like hypertension must be managed carefully, and TPA activator has been improved in neurological outcome. Then decompressive craniotomy is a surgical procedure that relieves the increased intracranial tension. Then subarachnoid hemorrhage may occur due to cerebral vasospasm. This cerebral vasospasm um, can be detected by this transcranial Doppler assessment or cerebral angiography. It is typically treated with calcium channel blocker, nimodipine, and aggressive IV fluid administration to avoid hypovolemia. Then early surgical clipping or endovascular coiling of aneurysms is advocated to prevent complications. Then status epilepticus is also a medical emergency. Cessation of seizures activity is required to prevent irreversible neurological injury. So lorazepam is the most effective benzodiazepine for treating seizures. Then brain death is also seen in critically ill patients. It can occur, which means a irreversible cessation of circulatory and respiratory function. So in ICU there is the diagnosis requires a lot of demonstration and the absence of cerebral functions, and lot of demonstration is required for a brain death. So in ICU, the most important thing is withholding or withdrawing the care. So in ICU, withhold or withdraw care if a patient or patient's surrogate makes such a request, or if the physician judges that the goal of the therapy is not achievable. So it should be a physician, patient, or the patient surrogate's decisions should be made. Like all of them should talk and decide for this, either for withholding or withdrawing the care. So the act of informing the patient or a surrogate decision makes the responsibility of the physician. It's actually the responsible of the physician to take this thing to the patient's surrogate. So the critical care provider should meet regularly with the patients or the surrogates to discuss the prognosis when the withholding or withdrawal of care is being considered. So today we covered around respiratory failure, ventilated patient care, then respiratory mechanics, circulatory status, then other preventive measures to be taken, then ICU monitoring. These concepts are a foundation of day-to-day ICU practice. I didn't go in deep into all this stuff just because it's very basic thing to know in ICU practice. So in next episode we'll talk about the respiratory system critical care and advanced ventilation strategies. If you found this lecture useful, don't forget to subscribe, share with your friends, and comment your doubts below.